Welcome everyone to the Making Connections webinar series presented by Seniors Health Knowledge Network. My name is Lindsay Toth and I'm the Technology and Admin Manager at SHKN and the facilitator for this webinar. Marguerite Thomas also joins us on the line today. She is the coordinator of the Fall Prevention Community of Practice and will be assisting with the webinar technology. Before we begin, I'm going to give you a quick rundown on the Level 3 web meeting system. This webinar technology consists of two parts. The audio is provided through a telephone conference line, and the visuals are provided through a web platform. The phone number for the conference line and the link for the web platform were sent to you by email after you registered for the webinar with Level 3. If you have questions about the technology at any time during this presentation, please type them into the chat box, located on the left-hand side of your screen. Alternatively, you can send me an email to lindsay@onf.org. I will work with you to resolve technical issues as soon as possible. This webinar will contain an opportunity for discussion during a question and answer period at the end. If you have topic-related questions during the presentation, please type them into the chat box. During the Q&A, I will read those questions aloud to the group. If you would prefer to ask your question over the phone, you may unmute your line by dialing *7. When you are finished, dial *6 to remute your line. This will help us control background noise. This webinar is being recorded. The recording and the slide deck will be distributed by email after the webinar. I would now like to introduce our speaker for today. Diana Deghofer is a public health consultant, the principal at Wellspring Strategies. Diana, you may now unmute your line by dialing *7.
Hello, everybody from snowy Rossland, British Columbia. Thank you very much for taking the time for this webinar. I hope you find it useful. I've been working in the area of social determinants of health for about 15 years, and it just doesn't seem that there's any area of health that isn't affected by it, so I'm really glad for this opportunity to present to you. I'm going to run through the first part of the presentation that deals more generally with social determinants of health fairly quickly so that we can get to the part that relates specifically to falls prevention, which I know is your key interest. So when we look at what determines health, we kind of look for those shiny red apples in the apple tree, the fruit of all of our labor. But obviously there's a lot of work that goes into developing those apples, and most of that happens in the roots and the trunk system. Those are where we would highlight the social determinants of health. It's that base in society that really determines whether we're going to have a healthy society or not. The World Health Organization divides the social determinants of health into three areas. Before I get to that, looking at what most people think about what determines health, lifestyle factors certainly play a large role. When I ask people, what they think makes people healthy, 80% at least answer diet, physical activity, and not smoking. That's certainly a small part of what determines your health, but those personal health practices and coping skills are just a very small part. So the next part, biology. Your genes have to determine your health. Again, it's not as big, doesn't make as big an impact as people think, probably 10 to 15% in most people's health. So the health system, the media, when it talks about health, talks about the health system about 65% of the time, according to a review of media reports that looked over the last 10 years of reports. Another 30% have to do with lifestyle factors. So it leaves very little to actually talk about those base issues that determine whether people are going to be healthy or not. As I said before, the World Health Organization divides those into three sectors: the structural determinants that really impact everything, and I'll talk about all of these individually. Material circumstances that flow from that structure. Do you have a roof over your head, enough food, and a safe physical environment? And then the psychosocial circumstances, so your social milieu, so where the personal health practices come in, and probably the most important part of this section is the healthy child development. Dahlgreen and Whitehead put together this graphic probably over 20 years ago now, but I think it still sort of demonstrates this scope of impact that each of these things have. So at the center of your screen, you'll see the age, sex, and hereditary factors. So those are your individual factors. And there's lifestyle factors around those, the social and community networks that you have, and then the broader socioeconomic, cultural, and environmental conditions. And the larger the arc, the more impact it has on individual health. The WHO takes a pretty political stance on social determinants, saying that these health inequities flow from patterns of social stratification that are systematically created for unequal distribution of power, prestige, and resources among groups in society. And I think this is getting a lot more play in political circles now. We're hearing a lot more about the gap in wealth and how that's creating severe problems. Everyone from, the Pope to the International Monetary Organization talks about the gap in wealth as being the most severe issue that they're dealing with now. So income and social status is certainly the most important determinant of health. Lower income and social status are linked to poorer health across the spectrum. And what's interesting is that it actually exists in a gradient. So at every income level, most social determinants of health data is divided into quintiles. So 20% of the population at the lowest level, you'll see has significantly lower life expectancy than those at the highest level. But it actually is stepwise all the way through. Females have more life expectancy than males, so that gap is closing. So essentially, except for the wealthiest in society, any work that focuses on the social determinants of health is going to help everyone. Education obviously influences people's ability to get out of poverty, their socioeconomic status, their income, their employment opportunities, even their social milieu, their network is stronger with a higher education. Stress is often related to a lack of control over people's life circumstances, and education is a good route to solidify that ability to deal with stress. Employment and working conditions. Again, good employment means financial security, social status, social relations, self-esteem, and protection from physical as well as psychological hazards. Precarious work, shift work, part-time work tends to be often at minimum wage and with very little security. Good union jobs, for example, will give people a whole lot more of a safety net than the general population will have. We're finding more and more Canadians are now self-employed, working part-time, have several jobs. Only 40% of Canadians are now eligible for employment insurance, which I think is astounding. Gender has a big impact. Women live longer than men, but they tend to have higher levels of disease, including mental and physical health ailments, much greater chance of sexual or physical violence. They tend to have lower income and unemployment and have a much higher chance of being single parents. And all of this relates to falls prevention as there are far more falls among older women compared to older men. The healthy immigrant effect refers to the period when immigrants first come to Canada, where they tend to have fewer chronic conditions and a longer life expectancy. That certainly diminishes over time, so the second generation shows about the same status as people born in Canada. Certainly mental health can be a problem, particularly now with a lot of the movement that we see among people being as a result of being refugees. That will impact their ability to adapt to a new country as well. Culture, the dominant cultural values certainly play a large role in shaping our society. A number of people have called for Aboriginal status to be a separate determinant of health in Canada. And the list that I gave you earlier is the one that the World Health Organization uses, but there are many variations of that. The Public Health Association of Canada has a different list. Dennis Raphael, who does a lot of research in this area and has written extensively, has a somewhat different list. His includes Aboriginal status, for example. So we certainly know that there is a much greater, there's a great disparity between Aboriginals and any other Canadians on just about any health measure that you want to look at. This slide I throw in there simply to show that there are opportunities for change. It demonstrates this suicide rates, the differences in suicide rates between Native and non-Native youth. It's dated information, but I think what's interesting here is that the researcher who pulled this out also showed that in communities where Aboriginal peoples, I think it was First Nations that he looked at specifically, where they've got self-government, where they have control over their schooling, their policing, their cultural centers, the suicide rates are virtually the same as the rest of Canadian society. So there are great opportunities to reduce these disparities. Material circumstances, these flow from those structural conditions that we talked about earlier. Having a roof over your head, having adequate food, and a safe physical environment are critical to health, clearly. Homelessness is something that we think of as, being shown as the guy on the street panhandling, sleeping in a shelter or sleeping outside when the weather's good. But homelessness really follows a continuum. And there are a lot more people, given the current economic situation, who have what we call precarious housing. So they may live in a house now, they may be renting, but they're one paycheck away from not being able to meet their rent. So that's a very high-stress situation and can lead to health issues, even if those people are not currently living on the streets. Again, knowledge that we can change this is well documented. The annual cost to support and house hard-to-house people, so people who are on the street with multiple issues, perhaps an alcohol or a drug dependency, the cost to house those people is virtually the same as what services are provided to them on the street. Food insecurity is basically people don't have enough money to put food on the table. It causes a great deal of distress and poor health. And we certainly find that in families, the parents are forgoing food to make sure that their children have enough to eat. The physical environment certainly relates a lot to falls prevention. How cities are designed, how communities are designed in terms of the flow of traffic, pedestrian walkways, bike lanes, those sorts of things certainly affect injuries. And again, the socioeconomic status of a person has a large impact because the poor people are more likely to live in substandard housing with, stairwells that aren't properly maintained, poor lighting. They may be close to major roadways. Their respiratory health may be affected because of pollution in the area. Children may not have safe places to play. What's happening now in terms of city development is that the downtown core is becoming more attractive to more affluent people. So we see a lot of gentrification. Poorer neighborhoods are being completely revamped, and richer people are moving in, pushing those with less income out to high-rises in that suburban ring. And it really changes the dynamic. Mom or dad can no longer watch their kids play in the street or in the backyard through a window. They've got a balcony, and they physically have to go down with their children to play. So there's a whole new dynamic around that has an impact on children's play and potential for injury. Psychosocial circumstances flow from all of those things that we just talked about and relate to the social environment, your individual social support, your personal practices, and healthy child development. The social environment refers to the level of freedom, democracy, those sorts of things in a society, volunteering, opportunities to engage in your community. Canadians do pretty well on the whole. I think being treated with respect and smiling are two things that I've heard from people who are homeless, people who live in limited circumstances are very important to them. It's not something that relates to material goods at all. It's just somebody looking them in the face and not ignoring them as you walk down the street. That was cited by one homeless person at a forum that I was at as the most important change that could be made in their lives, which I thought was pretty interesting. We do have a high level of community tolerance for minority groups, which I think bodes well for our changing society and the demographic that's changing with new immigrants. Social support is critical. A lot of people who are isolated tend to disengage from society. They don't take advantage of the opportunities for interaction that are out there for them. Their stress levels rise. They may not be as physically active because they don't have support to go out into the world if they're not, if they're not really well themselves. And the lower you go, or the more stressors are in a person's life, the more important social support is as a protective factor. Some researchers have said that social support has an as important effect on health as smoking, obesity, and high blood pressure. So certainly something to pay attention to. Lifestyle factors that we talked about earlier, exercise, diet, smoking, are directly related to the social gradient. Social status has a bigger prediction on whether a person smokes or not than just about anything else in North America. And obviously access to nutritious food affects health. That's impacted by income. It's also impacted by the neighborhood profile. Poorer neighborhoods tend to have fewer good grocery stores. Some researchers have associated those lifestyle factors and poverty directly to disease. So this shows the prevalence of diabetes in the various income quintiles. So you'll see that the highest income people have the lowest rates of diabetes, and it increases stepwise as you go along, to the point where some researchers have called poverty the greatest predictor of diabetes. And the length of time that a person lives in poverty impacts their chances of getting diabetes. So the more cumulative years of poverty, the higher your chances are of getting diabetes. Healthy child development, as I mentioned, is certainly the most important of the psychosocial determinants. I think we all know the importance of the early years. Poor children are likely to have low birth weight, lower growth rates, developmental and behavioral problems, and poorer health in adulthood. So family socioeconomic status is the main indicator of health disparity among Canadian children and youth. And we're seeing that in terms of their development, their readiness for school. So you'll see that 80% of children who come from rich neighborhoods are ready for entry into school, whereas only 65% in poor neighborhoods are. So again, there's a wide gap that impacts our not only our health but our ability to respond to economic and job market needs as those children grow older. The health system does have somewhat of an impact on people's health. Even though we have universal health care, the bottom third of Canadian income earners are half as likely to see a specialist and will wait longer than more affluent Canadians to see a physician. And we all know that our Medicare system does not cover many things such as eyeglasses, dental care, pharmaceutical drugs, assistive devices when we're talking about falls prevention. And the health system is starting to respond. Public health units are starting to locate clinics in lower income neighborhoods. helping people by extending their hours of operation, making sure that they're located on public transit routes. All of those things are important to make sure that health services are accessible to lower-income people. So, into the falls prevention piece, and I'll slow down a little bit here. Sorry if I kind of race through that. But we can talk more specifically now about how the social determinants of health affect falls and injuries more generally. So as far as your target audience, who is it that's most affected by the social determinants of health? Well, obviously people living on low incomes. Seniors and children in particular tend to be subject to more injury when they're in a low-income family. Aboriginal peoples are disproportionately affected. Injury is the cause of death at 3.5 times the rate for Aboriginal people than for the rest of Canadians. People with limited education, poor employment opportunities, as well as those living in rural, remote, or isolated communities tend to be more at risk for injuries. Obviously, people living with disabilities and mental illness, again, that social isolation becomes into place along with all of the physical issues that they're dealing with. People who are homeless and those who are subject to discrimination are all more subject to injuries. So if we look at low socioeconomic groups, there's a higher incidence and mortality rate among lower socioeconomic groups related to injury, all kinds of injuries, traffic, self-inflicted, poisonings, and in all settings. So if we compare the highest income earners to the lowest, those in the lowest quintile are 1.3 times higher to be hospitalized as a result of an injury than those in the highest income bracket. If those rates were equal across all socioeconomic groups, we'd have 21,000 fewer hospitalizations across Canada. And this is data from 2008, 2009, so I imagine it's higher now. The most common kinds of injuries are falls, motor vehicle injuries, and those involving cutting or piercing with sharp objects. The only group that have slightly higher rates, the only area where affluent people have slightly higher rates of injury are sports-related injuries because they can afford the mountain bikes and the ski vacations and things like that. So we do see some higher rates of injury there. And although it doesn't relate to you directly, risk of assault is 3 times higher in the least affluent neighborhoods than the most. So if we look specifically at falls, I don't have to tell you that the majority of falls are in the 65-plus age group. This is data that looks at hospitalization as a result of unintentional falls. The largest gap in between socioeconomic groups is actually in this age group, 45 to 64. It's kind of hard to see on this graph because it's overall the numbers are so much lower than in the older age groups. So clearly, if I were a practitioner, I would be looking at this older age group as far as prevention goes. So how, as a practitioner, can you take into account social determinants of health? I guess there's sort of 3 levels that I look at. The more universal you can make the program, the more people it will impact. And so obviously we have to continue to work for universal policies for healthy child growth and development, for healthy aging, and for positive physical and social environments. Cost barriers to taking advantage of the opportunities out there certainly have to be addressed. Regulatory changes and enforcement of the rules that we have in place are important, and advocacy in both of these areas is really the most important thing that practitioners can do. Health practitioners are seen with pretty high credibility. when physicians certainly get involved in social determinants of health discussion, it elevates the conversation significantly. And as health practitioners, you also have a strong role in your community and with your political leaders to promote a more equitable society. When we look at your practice in particular, I think sort of at the management level, it's important to recognize that there are audiences at particular risk and that they should be identified and given extra attention. So those impacted by poverty and isolation are certainly important. And there are some really good screening tools that have come out recently. Health Providers Against Poverty have developed a number of tools, including this clinical tool, which is a really very simple tool that should be asked of all patients, particularly among the elderly. Poverty certainly is not apparent. People will do their best to hide that they're living in limited means, and among older people, clothing doesn't always really tell the story because they're not going to be dressed in the most fashionable garments, but they likely have some good quality clothing that they will bring out for a medical appointment. So it's important to screen all of your patients, and there are a number of tools available either on the Health Providers Against Poverty website, or the Center for Effective Practice also has a number of pieces. So that I see more at sort of the management level, that those are processes that can be put in place and supported throughout an organization. Similarly, developing partnerships can do that, but that's also something that you can do at the individual level. Knowing what community organizations and what community falls prevention programs are out there can help you make those links between people that you think could benefit from them and the primary health care provider who may be the one that needs to make a referral to those programs. Referrals to occupational therapists as well can help in terms of, a home examination, for example. Recording who your patients are and what their socioeconomic circumstances are is important as well, so that we start to build those databases and are able to draw in from other sectors and make comparisons and recognize, through transportation accidents, through what's going on in the community and through police services, who is requiring more community services. And certainly doing what you can to increase awareness of the health impact of social determinants of health, even if it's as simple as refuting people in conversation when they say, the most important thing you can do for your health is to get enough sleep and eat right. The most important thing we can do for our health is make sure people have enough money to live. So specific practices have been studied to see where there can be the most impact on practices with lower socioeconomic groups. Certainly your communications needs to be more targeted. You need to take into account the higher stress levels and the mental state that people who live with limited means can sometimes be in. They sometimes feel like they really have no control, and in fact they often do have far less control over their living circumstances, the apartment that they're living in, the home that they're in, their job possibilities, their opportunity to get time off to go to see a health practitioner or to get out to a falls prevention seminar or program that may be out there. So all of those things need to be taken into account when you're providing support for people at risk. Certainly engaging the community in planning programs and services is important. You need to recognize that timing may be important. Programs may have to run after work hours or need to include budgets for taxis for elderly people who may not be able to get to the location of the program via public transit. They have to be low or no cost. They have to be in a location that people can get to. And certainly you need to be able to accommodate various language needs in your community. So I think a lot of micro programs, as opposed to one big blanket program, may be more effective in dealing with people of lower socioeconomic status, and providing them concrete benefits to coming to the class. So, for example, arranging for safety bars to be installed in a senior's bathroom if they attend this program, or to offer a home visit by a therapist who can go through the home and help the senior remove barriers that may be preventing their safe safe living in that environment. We know that legislation, regulation, and enforcement of existing regulations are helpful. There are a number of building codes to ensure safety in a home or an apartment, such as lighting and stairs and those sorts of things that frankly don't seem to be enforced as often as they could be. There are communities, for example, Montreal is taking a very focused look at ensuring that building codes are up to date as tenants move out and there's a transition. So transition periods are opportunities for that kind of enforcement that doesn't seem to be in place now. And that requires a partnership, obviously, between yourselves and city government to try to implement those sorts of things. Structural changes, as urban planners are becoming more aware of the connection between cities and health, we're seeing a lot more effort in terms of traffic calming, putting speed bumps in roads, putting more crosswalks, arranging crosswalks in places in the city where they're most required. My mom lives in a senior's home in a fairly busy part of Montreal, Hymas Boulevard, and the bus stop for the senior's home to go downtown is across the street. The closest traffic lights are half a kilometer either way, and there's no crosswalk. So that kind of situation is clearly creating a hazard for seniors who want to take advantage of transit, get out, and become more engaged in their communities. There's a long history of work on age-friendly cities and communities, and the WHO's framework provides some good information on how to work towards that. I talked about home safety a little bit earlier, and something that I think is very helpful to people on low income and seniors living in rented or shared accommodation is that home safety assessment to make sure that lighting is in place, that safety features are identified, needed safety features are identified and installed, that maintenance or repair issues are reported to the landlord, and that common areas are maintained properly. Building a social determinants of health oriented practice involves that kind of, work at many different levels. Looking at the documentation and the partnerships and the arrangements that need to be made across systems, so that we have a good idea of who the most at-risk people are. And that all organizations are focused on supporting them. And that's something that more health organizations are starting to do, is to take down data regarding socioeconomic status, race, language, gender, those sorts of things to help identify patients who may be at risk of various health issues because of their social status. A number of public health units, all public health units in Ontario now have social determinants of health practitioners who are deployed in various ways throughout the organization to help promote practice that is more oriented towards the social determinants of health. And it can be done in many different ways. I just completed a case study for the National Collaborating Centre on Determinants of Health, and we looked at 4 public health units in Ontario and how they used very different ways to instill a social determinants of health orientation into practice. A lot of it has to do with developing partnerships and relationships with people in, the traffic department, economic development, partnerships outside of the health sector, which definitely make it more challenging than simply working with your clients. But they have by far the longest, the longest term, the biggest impact. Working at the individual level as well as advocating for social determinants of health practice throughout systems is pretty critical. So a lot of this information you can find on the website of the National Collaborating Centre for Determinants of Health. It's one of 6 collaborating centres that is funded by the Public Health Agency of Canada, and their job is basically to translate information around the social determinants of health. So they also have a community of practice and a lot of easy-to-read resources that help identify specific elements of social determinants and how to address them. For this presentation, I looked specifically at some of the falls prevention data. The Atlantic Collaborative on Injury Prevention is a great resource if you're not already aware of it. They produced a 55-plus page a handbook on dealing with injury prevention as it relates to social determinants of health. So that's a great resource. High, as you know, has lots of good data to draw from, and then there was some specific research done on Canadian seniors that I looked at as well. So that is basically the presentation. I hope I didn't rush through it too quickly, but I did want to leave lots of time at the end for your questions. So please fire away.
That's great, Diana. Thank you so much. So just a reminder, you can type your questions into the chat box on the left-hand side of your screen. We can also open up the telephone lines for people who are interested in speaking over the phone. So let's go to one of the questions in the chat box first. So Marguerite asks, only 40% of workers are eligible for EI and the proposed financial support for caregivers. However, many caregivers are seniors themselves and eligible for nothing. Should being an older caregiver be added to SDOH?
Well, yeah, that's a very good question, Marguerite. I think it's becoming more and more of an issue with our aging population, and certainly there has been more focus on the fact that a lot of caregivers are older themselves. I think that it would be there certainly should be consideration given for that as a social determinant. But again, it would be very closely linked to socioeconomic status because older people with a lot of money can afford caregivers to come into the home and help with that. The main question in the screening tool that I mentioned, created by Health Providers Against Poverty, basically it just asks, at the end of the month, do you have trouble making ends meet? And whatever anybody's circumstances are, whether they're single parents or an older person looking after a spouse, that question will, raise a flag that this is someone that may need more assistance. And I think that would identify those people that you're talking about.
Thank you. Okay, another question. Oral health is strongly related to good nutrition. How can we promote affordable dental care for older adults and not just children? Both
of your questions so far really relate to advocacy, and that's something I hear over and over and over again, no matter what issue I'm looking at as far as determinants of health. I recently did a review that looked at mental health, homelessness, child development. Sorry, the fourth topic escapes me for the moment. But talking to key informants across the country about what needs to be done to take more action in these areas, and the response across the board was advocacy. Health providers have to become much more active in advocating for their patients at all levels of government, and certainly oral health would have to be covered provincially, and there are certainly moves. I've seen just recently the BC Public Health Association was asked to endorse a call for free dental care for seniors. So there are moves afoot to do that, and I know it can sometimes put health professionals in a little bit of a difficult situation, advocating to their employer essentially for what they think is required, but working with community groups and with larger petitions and umbrella organizations can help take away that direct link between employee-employer and help health professionals become more active in advocacy.
Thanks. And I think Linda Strobel is on the line. And Linda, I don't know if you want to maybe hop on here by dialing *7. And I know you've done some advocacy work around building codes and been involved in that. Do you want to talk a bit about your experience? Or anyone else who was involved in that? So it's *7 to unmute. Maybe we don't have her on the line anymore. That's okay. But I know here in Ontario there has been some efforts over the past couple of years around updating the building codes, first for stairs and now around bathroom safety and installing grab bars, making that mandatory for builders. So if anyone's interested in learning more about that, if they want to send me an email afterwards, I can connect them with the people who were sort of leading those initiatives. They'd like some more information about advocacy for building codes. Okay, so moving on. A question from Betty. Are you aware of any fall prevention programs using a model whereby seniors help each other?
Yes. I would need to go back over my research. This is probably a couple of years ago that I did uncover a program. I'm pretty sure it was in Toronto. Maplewood comes to mind, but before I misspeak, let me look into that, and I can send Lindsay that resource after the webinar. But it was definitely a seniors peer support, peer directed program, and I'm pretty sure it involved immigrant women as well. So I'll look into that research and send that reference over.
Thank you. So we do have Linda on the line. Linda, do you want to try unmuting yourself one more time? We'll see if we can get you unmuted. Dial *7 on your telephone keypad. Okay, it's not working for us today, unfortunately. All right, we'll move on to the next question. From Lara. Excellent presentation, Diana. We have a difficult time advocating for and obtaining resources for physical activity for older adults, which we know is effective, let alone looking for support and resources relative to SDOH to support fall prevention and other issues. Do you have any suggestions, templates, resources to recommend and help us with both physical activity, advocacy, and SDOH?
The one area that I think that we need to do more work on, I haven't really seen, a good accumulation of data that talks about the direct economic impact of physical activity on seniors. I mentioned the research that we have on housing. So there are pockets of data that are available that link a particular issue or a particular group to the economics of resolving that. But I haven't seen it for seniors and physical activity. I think that it's a gap overall. Generally, I'm sure I don't need to tell you all that you need to create an argument that's going to be most compelling to your audience. And if it's a question of finding resources, then demonstrating the economic case is prime. And I think that there's still a gap in that area that needs to be addressed. I've proposed it a number of different times. As a consultant, I kind of have the opportunity to work with a number of different organizations and can kind of sort of scanning national, provincial, as well as local initiatives, have a pretty good sense of where those gaps are, but there seems to be some reluctance there, and I'm not exactly sure where it comes from, but it's definitely still on the to-do list at a high priority.
Thank you. Question from Linda in the chat box. Do you know of any fall prevention or health promotion data or initiative with on-reserve Canadian Aboriginal or First Nations? I see so much in terms of socioeconomic status, income gap, safety gap, housing maintenance, and built environment, which supports safety and healthy aging.
I don't know of anything specific to falls prevention, but in British Columbia, we're divided into health authorities. Most of them are regional health authorities, but a couple of years ago, a new health authority was created, which is the First Nations and Aboriginal First Nations Health Authority. And I would go to their website. They're doing a lot of work in terms of pulling together data on the health status of Aboriginal peoples. I'm sure you know that it's been a gap in the research for a very long time, that there has not been very good information on what's going on. Probably a little bit better on reserve, but certainly not in terms of Aboriginals living off of reserve. So I would check the First Nations Health Authority in British Columbia. I would also look to the National Collaborating Centre for Aboriginal Health. It's one of the 6 centres that I referred to earlier, and they've got some great reports, some great data on Aboriginal status.
All right. Diana, did you lose your screen as well?
I just lost my screen, yes.
Okay.
I've got an evaluation up.
Yeah, okay. So I'm thinking we had a technical issue. It seems that someone signed me out. So unfortunately, I remember the next question on the queue, but I don't remember the ones after that. So we may need to have people hop on the phone line if we didn't get to your question. But we'll.
Hello, Lindsay. This is Marguerite. Can you hear me?
Yes, we can.
The suggestion was made in the chat box about continuing the questions and also looking at the resources that people are posting on our website, which is Loop. And people can do that by going to www.fallsloop.com. And the middle is FALLSLOOP, fallsloop.com. There is a lot of interest in this. There are more questions, and we would love to keep the discussion flowing and the resources being shared.
I do recall one of the questions related to the fact that a lot of the the structural changes to address social determinants of health are outside of the authority of health organizations, that they involve other ministries within the government. And that is certainly a huge issue. We have seen a number of cases where that's been overcome through interministerial working groups. So, for example, in Manitoba, the Ministry of Child and Family Development, I think it's called, has representatives from employment, economic development, and a number of the ministries that impact most directly on social determinants of health. So it's difficult as a practitioner to see your way to that high level of change, but if governments can be convinced that interministerial groups are the best way to address these sorts of issues, then we've seen that working quite well. Poverty reduction strategies. In the provinces, well, British Columbia is the only province now without a poverty reduction strategy, but that by its nature tends to be intergovernmental, and they are applied, in various ways across the country. New Brunswick, I think, has done a very good job of sort of setting some broad parameters of what they want to address in poverty reduction through an extensive community consultation, and then moving the locus of control back to the community. So community organizations are invited to apply for funding from the Poverty Reduction Initiative and have to be structured such that they include representation from employers, community organizations, schools, a number of sectors in the community. In Newfoundland, a number of years ago, the deputy minister, or she may have been an assistant deputy minister, but a very high-level member of the employment and I can't remember the exact name of the ministry that they use, but essentially the ministry responsible for employment and working conditions was a public health practitioner, and she was moved into that role to put that lens of social determinants on the work of the ministry responsible for employment. Language, recognizing what language will resonate most with other organizations is important, and there's been quite a bit of work done on that. Some of the terminology around social determinants, equity, terms like that tend to be value-laden, and so there has been quite a bit of work done it's mostly been done in the U.S., a little bit in Canada as well, but looking at ways to engage people from all political stripes in addressing inequities. So using phrases like, leveling the playing field, giving everybody an equal chance. Things like that resonate with people no matter, whether they're very conservative or left-wing. And so that kind of thing is important to start those conversations, to build the bridges required to address inequity. It's a very complex question. I think it was a fellow named Doug who posed that question on the chat group about, the interministerial need for action. It's very complex. I'd encourage you to go to the NCCDH website because they have quite a bit of information on how that has been implemented.
And we can send out that link in the follow-up email because we don't have our chat box function anymore to do it.
Mm-hmm.
I know there was a question. I saw one. It was around physician screening and the tool.
Right. Yes, I remember that one as well.
Ask that question still online. *7 to unmute if you want to ask.
Hi, can you hear me? It's Rhonda.
Hi, Rhonda. Yes.
Hey, I just wanted to say I'm in Loop right now, starting a discussion forum around fall prevention and the social determinants of health. So for those of you who aren't currently registered on Loop, it takes honestly just a minute to do that. And if you are already registered, feel free to go in there. I'm going to have it up in just a few minutes so we can continue the discussion here as we are for the next few minutes. But there will be a discussion forum on www.fallsloop.com, as Marguerite mentioned earlier. That'll be a place to share any resources and whatnot related to the discussion that we're having today, and to just keep the momentum going. So I'll go ahead and start to post some things in there that have been brought up, including some resources relating to Aboriginals and fall prevention.
Great, thank you.
And yes, I do recall the question about the poverty intervention tool.
Okay.
And yeah, the tool's been adapted for various provinces, but definitely the aim is to ensure that the tool also provides ways of acting for physicians. I think the person asking the question noted that physicians are reluctant to move on anything that they don't feel that they can address. So they don't want to ask people about an issue if they don't feel that they've got the tools to actually support them in addressing that issue. And yes, the intervention tool is designed so that it not only identifies people who are at risk of poor health because of their socioeconomic status, but provides a number of tools to help them overcome it. So asking about, have you filed your income tax return, because that can open up opportunities for people, and listing specific opportunities, clinics that people can go to, social workers who can help people actually fill out forms that are required. So it can be applied in a number of different ways. I know that in BC, a number of medical centers have hired social workers, so that when our patients are flagged as being at risk, they'll be seen immediately by the social worker, who will go through all of these questions with them, help seniors apply for old age security, the guaranteed income supplement. So there are definite specific actions that are recommended in the tool.
That's great. So I think that's all the time that we have for questions today. I do want to just make one more comment. Diana, you mentioned age-friendly communities in your presentation. I do want to say that there is a lot going on with age-friendly communities right now in Ontario, and the Seniors Health Knowledge Network is helping to support some of those initiatives with funding from the Ontario Senior Secretariat. So I know Marguerite did post a link to more information about age-friendly communities in Ontario in the chat box before we crashed, but we'll send that out again in the follow-up email. And there is an age-friendly communities planning guide that communities who are interested in adopting an age-friendly technique can follow the steps in this guide. And then there's also currently a webinar series going on that takes all the steps in the guide, breaks them down, and does one webinar on each step. So a few of them have already been covered, and they're on our YouTube channel. Again, I'll send the link out. But there's also two upcoming ones, one on developing an action plan, and then one on implementation and evaluation. And the dates for those are this Thursday, January 21st, and then Friday, February 12th. So again, I'll also throw those up either in Loop or the follow-up email, so that if you want to have a look at those webinars that are coming up and maybe register for one, you have the opportunity to learn more about age-friendly communities as well. So I wanted to say thank you so much, Diana, for that incredible presentation, and I think it was really eye-opening for a lot of us. And
you're very welcome.
Something that doesn't get enough attention, I think, especially in fall prevention. So thank you for providing that evidence-based information for us.
I'm really glad I was able to help.
Great. And I'd like to thank all of our participants for attending today and engaging in a great discussion. Thank you for your questions, and I hope that we can continue that discussion on Loop afterwards. So I'm hoping that you all now have an evaluation survey on your screen. So if you do have a couple minutes to give us some feedback on the presentation and maybe on the technology as well, that would be great. And then a recording of this webinar will be posted on our YouTube channel and circulated to all the participants in the coming week or so. You're free to pass it along to any colleagues that you think might be interested. For more information on the Seniors Health Knowledge Network, you can go to seniorshealthknowledgenetwork.com. And for more information on the fall prevention community of practice, you can go to fallsloop.com, which is the communication platform for the COP and where we will continue this discussion afterwards. So thank you, everyone. Have a wonderful day, and we'll see you next time.